Well, let's continue here tonight. South Africa legalized abortion in 1997, and it can be done within the first 12 weeks of pregnancy. Thereafter, women who are pregnant for 13 weeks or more can terminate under certain circumstances. Abortion is free at government hospitals, but however, few clinics offer them, and many women risk their lives using illegal abortion facilities. Tonight we'll question why this is the case. We're joined by the UN Special Rapporteur on Right to Health, Dr. Tlaleng Mofokeng. Dr. Mofokeng, good evening to you, and thank you so much for your time. It's been some time now that the termination of pregnancies has been legalized in South Africa. One wouldn't say that is the case when it comes to the actual reality of the delivery of those services to women across the public and the private sector.
That's very true, Kathy, and I think today is a very sad day for many of us who are working in the sector. We've lost our guiding light. We've lost a person who was giving us so much strength, Professor Sanga. And speaking of the Choice on Termination of Pregnancy Act, we can't speak about that act without talking about his incredible contribution in drafting that bill, in supporting civil society and supporting the parliamentary process. As we know, it was highly contested. And honestly, we've lost a professional, we've lost someone who was an excellent academic, an exceptional clinician, and someone, by the way, who inspired me to do this work and do it in the manner that I do it. He used to be my teacher and consultant at the University of KwaZulu-Natal, and at the time he was the head of department. So I know that many of us have very heavy hearts tonight as we feel really his loss. But I know that his work, his legacy is written in ink, and he will live through all of us. So I just wanted to take that moment and send condolences, especially to his family, his wife and daughters, as well, of course, as his friends and colleagues. We will miss him dearly. It's really just a tough time. But in any case, you are correct. The reason why the Choice on Termination of Pregnancy Act was important in South Africa was that we needed to give a legal framework in how to provide services for people. We know that in any case where there is stigma, there is discrimination, there is criminalization, it often impacts the people who are most marginalized, which are, in this case, women and girls, because this issue is gendered, poor women who can't afford private services, women who are migrants who don't necessarily have a proof of address, right, to access a clinic facility. But we think about the intersecting issues around people who use drugs. We think about the needs of sex workers. And anyone in this country who requires a termination of pregnancy for any reason up to 12 weeks is allowed to do that on paper. But in theory, in practical terms, it's not as easy as that.
Dr. Tlaleng, let me extend my condolences just on that note to yourself and the medical fraternity just on this loss. You talk about intersectionality, and when it comes to the issue of access around termination of pregnancies, it speaks to broader challenges around access to the healthcare system for many women in general. It doesn't begin and end with termination of pregnancies.
Absolutely. And because termination of pregnancy is a timeless medical condition, we tend to, of course, talk about it more simply because of what it means when there are delays. We have many people who still have to save for transport money to be able to access the nearest health facility to them, and that often means there's 2, 3, 4 weeks, that advance once a person has made that kind of a decision. We also know there's incredible stigma both in society but within the health system as well, and this keeps people away because many experience verbal abuse. Many experience and very unsavory moments even when they do get that procedure done. And I think what's important is to talk about the incredible work that many healthcare providers, abortion providers around the country have been doing for many decades in trying to destigmatize the issue of abortion access. And Prof. Eddie was one person. He always introduced himself as Professor Sanga, who's a born-again Christian, who's a man who's had a vasectomy, but also is an abortion provider, to try and destigmatize that even within the medical fraternity itself, and really led the way to show all of us how even as healthcare providers, we can be spiritual, we can be religious, and still, do our duties in terms of the duty of care and the guiding principles of medicine. But the stigma, I think, that's deeply entrenched in the health system is what's keeping all of us back, and the lack of training in undergraduate and postgraduate in terms of the clinical skill of doing the procedure.
So what does that mean when you have this challenge of access to certified, accredited facilities? What is happening in the backspace for women who are accessing unsafe terminations?
So part of the problem with South Africa is that we don't have a clear plan on how we are going to react to the misinformation that's online. So if you have to Google or look for any facility, you are going to be inundated with so-called clinics that are not clinics, that are not health facilities, that have no trained professionals. But people know the desperation, right, and the absolute need that many women and girls have for the service. And so one of the things we need to do first is actually stop the illegal posters that you will see on the outside in public spaces. We need to target and be clear on online spaces as well, because a lot of people get misinformation around when they can get an abortion, up to what stage, and the methods used. And so before they can even come to a health facility, they are already having so much misinformation. So even the counseling process takes a while, because we actually have to do so many undoing, right, in that process before we can even get to the procedure. The other thing is a lack of commodities. So to actually do a safe abortion in any setting in the health facility, there is just bare minimum things that you need. And some of the medications are still being imported. We don't have generics, and they cost a lot of money. So whether or not you can actually afford to have it in private in this country, it's actually still very costly. So that even those, unfortunately, with medical aid, they don't always get the cover for this procedure. So it means women are paying out of pocket. What it does mean is that it increases the number of unsafe abortions. And the WHO is very clear in terms of the definition. This is an abortion that is done either by a person who's not a trained healthcare professional, or it's being done in a facility that is not actually a healthcare facility, and it can be a combination of the both most of the time. We know that many people are selling and posting these pills to women at exorbitant amounts of money, and sometimes they're not even getting the correct treatment. So the problems are many in terms of unsafe abortions that lead unnecessarily to complications, because done safely with expert hands, with trained hands, it is one of the most simplest and safest medical procedures. So no one should be dying from trying to access an abortion.
Let's talk about the reasons sometimes that influence why a woman would choose an illegal facility to administer this versus a legal practicing facility, especially when you talk about the societal pressures, the level of the level to which this conversation is still considered taboo to a certain extent.
And one of the ways that we're trying to break that, right, is to affirm this as a medical procedure. It is a medical need that requires a response, that adheres to the principles of primary health and medicine, which that the service must be accessible, it must be acceptable, it must be of quality, and it must be affordable. If you have any way where the service is either unacceptable just because the people are rude, or the quality is poor, or it's unaffordable, we are already failing women. And we need to understand that this is not the individual failure of practitioners, because we have to work within a particular health system. So we need a whole system that will change to enable access. One of the most important things, Kathy, is that when people have decided that they want to terminate a pregnancy, they have to visit a public health facility sometimes twice, 3 times, 4 times just to get the procedure. And if you think about the intersections of women who are already in low-paying jobs with no labor protections, how many of them can afford to take 4 days off consecutively, sometimes over a month, threatening their jobs? So a lot of second trimester terminations in South Africa could have actually been done as medical abortion in the first trimester quite safely, more than 97% success rate, but they are not done that way because of the continuous delays in the system, whether it's administrative, whether it's because of just having no trained medical professionals to perform the procedure, or there are just simply no commodities. During COVID, we had to go 3 months without one of the key, medications that are needed for this procedure.
What are the consequences of unsafe terminations? I think it's important that we talk about those.
So unsafe procedures, and I have to tell you why people then still go to illegal, or what we actually prefer to call unsafe providers, is that sometimes it works, right? So there is that issue of word of mouth, where we tell each other, I went there and it actually worked. And so it's not true that every unsafe procedure, or one that is given by an illegal provider, will not work, right? It does work, and that's why women keep going there. But we know that when it doesn't, it can be catastrophic. You can have bleeding, which is hemorrhaging that is not controlled. You may have infection that leads to sepsis later on. You may require admission long-term for IV antibiotics. If it's so bad, the hemorrhaging, maybe a combination of sepsis, you may even require an ICU treatment. And we always say, if you are making an economical case, because a lot of policymakers respond to that kind of discussion, it costs far less to offer women safe medical abortions when they present the first time than to delay them, where they end up having unsafe procedures and then actually having the very health system manage the complications, which actually cost the healthcare budget that much more. And it's about accepting and defending and respecting people's autonomy, giving them treatment that will affirm and uphold their bodily integrity. And at the end of the day, all of us volunteered to be nurses and doctors, and therefore we should adhere to the code of conduct and to the medical ethics.
Just before I let you go, are there low-hanging fruits? So are there maybe 2 things that could be done differently from tomorrow that could have a significant impact on how this conversation takes place in this country, and also how the access to these services is improved?
So there's a few, I suppose, self-funded, events and seminars that I've been holding for the last 6 years. And on the 28th of February, I'll be in Cape Town, beginning the first of those seminars. 5 of them will happen across the country, where we call them advocacy in practice, where we assist undergraduate nurses and doctors and those who've qualified with the skills, because most of us know what's wrong, but we often don't understand and know how to actually then take the action. So it's going from, here's what's wrong in the clinic. Maybe it's a pharmacy issue where they're not ordering the medicine. Maybe it's the health manager issue who locks the key in the clinic and takes the key home with them, It may be a variety of reasons. Maybe it's because we don't have training and protocols, and therefore we assist them in identifying the problem, power mapping, and identify the key stakeholders, and then take action and measure what that looks like for them, because we can only do so much. But what's also important is that many of us are continuing to do the work of communication, health communication, and giving patients information. But we need a system that's not dependent on a particular person being in charge. We need the policy and the act to have life and bear what it's meant to do in terms of saving lives of women, but giving access that doesn't depend on political will or who is the minister, for example. That act has to be respected and fulfilled as per the state's obligation in any case. And even if you look at international human rights law, that is the bare minimum. We have to respect, fulfill, and protect the rights of women and girls.
Dr. Tlaleng Mofokeng, let's leave it there for tonight. She's the UN Special Rapporteur on the right to health.